There's a lot of congruency arising out of papers this morning, and a lot of it is to do with the validation of past trauma and an appreciation of the etiological significance it is in the evolution of a wide range of trauma-related mental illnesses. This cartoon probably is in keeping with that, the way in which, since time immemorial, we have tended to blame the victim. And here we have, this is from the early days of the motor industry, and it is a man who's just run over a poor fellow on the road. And of course, he's saying, "Why don't you get out of the way?" And the victim's saying, "What, are you coming back?" There's been a lot of consideration today about the problems of the non-recognition of trauma-based syndromes or the invalidation of those that have been very traumatised. And I thought I might, not because it's highly original or highly instructive perhaps, but I thought it might be useful to actually outline how I became involved in trauma-informed care before there was such a term, and how I ended up establishing and directing what must be Australia's first inpatient and associated day hospital trauma-informed care program in Australia. And that was before we knew it by this sort of terminology. Going back to the late 80s, early 90s, I became aware that more and more, as I became aware and checked it out more and more, that so many of my patients had trauma histories. And this was at a time, and I think Richard talked about it this morning, where the standard textbook of the day had incest as occurring as a 1 in a million phenomena. And that was still present in the 1980 version of the comprehensive textbook of Friedman and Kaplan and Sadok. And I also became aware that of such patients who gave these sort of histories as going into other states and running out of the room or not remembering things, all of which was fairly perplexing. By way of perspective, at that time, multiple personality, which is now known as dissociative identity disorder, was considered a vanishingly rare event. Considering incest was so rare, this was even rarer than incest, which meant that in the average psychiatric career, no one was ever expected to ever see such a case. Now, if you hang around and start with such patients and start taking detailed histories, sooner or later you actually, even though you've never had any instruction in this, you're going to discover somewhat of a key to interpreting what's actually being played out before you or what's being said. And about 20 years ago, before I'd ever had a conversation with anyone who'd ever told me that they'd ever met anyone with multiple personality disorder, I actually discovered it, as it's been discovered many, many times over. And contrary to those thoughts about, quote, borderlines being so sort of difficult that the best form of treatment is referral, and I actually find these people extremely interesting people with ultimately usually far more right with them than there is wrong with them, and what's wrong with them is not caused by them. However, it was an interesting sort of cultural shock to a system, particularly as I worked then in the largest teaching hospital in Queensland. It probably was a challenge of paradigms to suddenly have such patients being diagnosed and assessed, and their diagnosis appearing in clinical files and public records and so forth and so on. I might add that at the time in Queensland, the publicly distributed documents about mental health policy that came out from the State Department had a lot of material about stabilising and maintaining patients. Not a single word ever arose called treatment. So you didn't actually treat anyone in public mental health, you maintained them or stabilised them or warehoused them. And we're still struggling with this issue. Miranda earlier today talked about the issue of serious mental illness. My definition of serious mental illness is pretty much akin to my definition of serious physical illness. Serious physical illness is any physical illness that has a fair chance of killing you. And serious mental illness, by my definition, is any mental illness that has a fair chance of killing you. I think that's just a very basic, fairly common sense way of looking at it. Now, I was back in the early 90s, I suppose I was reaching that point of decision-making in career that if I stayed on much longer, the inevitable fate of any, I guess, public psychiatrist that actually was fairly active was that you became an administrator, which meant that fairly rapidly you became largely separated from much patient contact. You attended meetings and responded to ministerials and waited around until sooner or later some public scandal would happen, and then you would be offered up as a scapegoat. And I'm not being totally cynical because I've just seen this, and I totally empathise with the people that it happens to, that they struggle with systems and then something happens and the system turns on them. I also found treating patients and researching patients much more interesting than attending whiteboard meetings. And at that time I also had a joint appointment as an academic. I also came to the conclusion in dealing with these sorts of patients, of which it's been pointed out to some degree probably the majority of all patients in the mental health system are in this spectrum. It became apparent to me that in an academic career, again, you end up attending awful lots of meetings, curriculum committees and so forth and so on, and you become largely clinically removed. So by way of my personal journey in this, I decided, one, to leave the public health system, and two, not to become an academic, though I very much appreciate having connection with multiple academics. I also was aware that when one is actually developing a paradigm, it's really quite useful to be well credentialed. So I completed a doctorate, which is a bit unusual in order to go into private practice. Within 15 years ago, I was involved then in establishing a working model. It became apparent that it's one thing to talk about these things or give anecdotal accounts of such patients, but in fact, in order to advance the field, to me it seemed that we actually had to have some hard data, which meant that I was involved for several years in collecting data, along with a colleague, Jeremy Butler, on 62 patients who fulfilled diagnostic criteria for dissociative identity disorder, and describing in reasonable detail the phenomenology, abuse histories, etc., which showed, in fact, of course, that such patients were just as common and had very similar symptomatology and abuse profiles as those in North America, which was the centre in which most of the literature was emerging. In order to actually go further with that process of actually gently offering an alternative paradigm, it's one thing to actually establish that the condition's there. Then the next step, of course, is to actually put in place a working model. Now, it's an interesting thing to try and establish a unit in the private healthcare system. I mentioned the public system. It has its particular challenges. In the private system, the main challenges ultimately tend to be health corporations. And we're not driven by any issue about government policy so much, other than where it affects revenue. And in order for a workable treatment model to be introduced, it has to be, above all things in that system, profitable, and it has to be acceptable within mainstream psychiatry. My policy has always been to see severe psychological trauma as a mainstream issue. It's not some rare subspecialty. It's a bit like saying to a cardiologist, is the heart a subspecialty of cardiology? You know, to say, is trauma a subspecialty of psychiatry, is to remove most of the whole. In order to further a model, one had to do ongoing research, publish, and be involved in educational activities. And from very early on, from the early 90s onwards, I have been involved in, as either subsequently as a director of the Trauma and Dissociation Unit or through the Cannon Institute, which I've chaired now for a lot of years, involved in putting together conferences, seminars, workshops, dinner meetings, etc. And there's an old saying which says, never try to teach a pig to sing. It wastes your time and it annoys the pig. Which is a slightly blunt way of saying, don't waste your time trying to convince people of things they don't know. My approach has always been to be as respectful as possible. And if you are invited to a meeting, you know, with people who hold different views or you felt have unresolved issues, if you can, go and be a model of consideration, of give and take, listening, and as soon as you, and I know they understand the temptation, but as soon as you go and attack somebody publicly, and I've seen this happen within the trauma and dissociation field, where people have gone into print talking about the negligence or incompetence of their colleagues, that may be true, but boy, it doesn't convince anybody. If you're actually trying to get a paradigm accepted, don't appear like you're dangerous. If you go under the assumption that this is mainstream psychiatry, it's accepted by many, and if you offer, without sort of moralising about it, a model that is acceptable, that you've done solid research on, that you will accept ongoing research students. And in fact, the Trauma and Dissociation Unit had Dr. Martin Dorahy working with it for some years, and Martin, I was his joint PhD supervisor, and he completed the first PhD in dissociation in Australia. Non-controversial. I might add, when we published our series on DID, which is on 62 patients in 1998, it's sort of interesting. It didn't attack anybody, and I never got any hate mail. No one's ever questioned what was there. It's pretty unassailable. One thing that gets people into enormous trouble, and it happened in North America to a large degree, is where people in the trauma field go beyond the verifiable data. They see one patient who gives a story of things that aren't historically accurate or may not be historically accurate but certainly can't be proven, and then they extrapolate from that into wild speculations about what's really going on in situations that they've never directly visualised. And when we were establishing the Trauma and Dissociation Unit, of course, about that time was about when the peak of the false memory syndrome controversy, satanic ritual abuse controversy, suing of therapists, etc. in the US was sort of reaching fever pitch, which is an interesting thing because units were closing in the US as we were opening one in Australia. I didn't mention that too loudly to the private health corporation